Good afternoon, good evening, everyone, wherever you're joining us from today. We want to welcome you to the Nurse Policy Entrepreneur Cafe. We believe that nurses are well positioned to incorporate health in all policies because we're the first witnesses to all of the determinants of health, and we keenly understand that health system strengthening expands beyond traditional direct care roles. Nurses work in multiple spheres of influence to shape health and social policy that addresses problems in healthcare, including in the workspace, in government, associations, and in civil society at large. The origin of the word entrepreneur comes from the French language that denotes a person who undertakes a project. So this doesn't necessarily mean business entrepreneurship. This concept is not unfamiliar to nursing professionals, and societal changes have been initiated by individuals who have observed a problem and figured out how to disrupt the status quo and the equilibrium to improve something. And policy does not always mean politics, and deriving effective change does not always mean running for office to do so. A policy is just a set of ideas or a plan of what to do in a particular situation. The Future of Nursing report has a multidisciplinary call to action for nurses to assume leadership positions and serve as full partners in healthcare reform, from practice to policy, including in decision-making for national policy. And nurses must prepare to engage regardless of our practice settings. Nurses, as the largest constituent profession, have maintained our status as the most trusted profession for decades, yet we're rarely engaged in the process of healthcare policy making. The concept of nurse policy entrepreneurs, while it's been practiced for centuries, is often overlooked, and this gap is not only from our invitation, but also our struggle to identify as thought leaders in this arena. So, becoming engaged as a thought leader and policy influencer is an element of our professional identity, with the beauty of diversity in our individual perspectives, personalities, and leadership roles. If we leave it to other disciplines to determine healthcare policy, whether they are healthcare providers or not, reform will be marginalized. We must become known as more than just the trusted profession, but also as the most influential when it comes to policy, because we have the highest touch points in healthcare. So, how do we address these issues? As the complexity of policy increases, a higher degree of expertise and skill sets become more important. It becomes harder for individuals to influence policy. But if we foster dialogue, inclusivity, innovative thinking, we can better understand how to engage. Our methods here at the NPE Cafe are based on theory to address the gaps between ideation and action. We promote diverse insights for meaningful evolution. We use Parsi's human becoming community model to describe how the concepts of co-creation lead to community building and evolution. And the World Cafe method is the gold standard that establishes a psychologically safe environment for collaborative innovation and shared learning. There are three change concepts that might seem paradoxical at first, but they really complement discussions and shared learning. This includes moving and initiating. Think of how we shift between somewhat chaotic discarding and creating of new ideas and meaning as a result of these conversations with others. And then we have anchoring and shifting. So recognizing that when an idea improves your previous thoughts and shifting them after this contemplation, or anchoring further down in your previous thoughts and making them stronger as a result. And another one is pondering and shaping, so dialoguing and then meaningfully listening to complete thoughts of others. This is the basis of our cafe that we host once monthly. We have no affiliations, no paid membership, no eligibility criteria that prevents getting engaged, no barriers, and no borders, because nurses need an organized process to meet, network, and discuss approaching these issues, not debating our stances on them. In holding this space, we create structural empowerment for nurses to become effective policy makers and implementers, while simultaneously exploring how to create a system for true deep democracy at all levels to improve our communities. It breaks down imposter syndrome because by facilitating this evolution and guiding nurses through group mentorship to resources and inviting them to be active, you embody what you believe to advocate in new ways. We are open to all nurses and students at all levels and in all settings across the world. Now, you can start with your own preparation. You can clarify your why, your reason, your purpose, how you got into nursing in the first place, and continue to develop an expertise beyond your clinical expertise within hospital walls. Create a personal professional development plan. Find organizations that share your why, share your values, and join them, and be able to engage with them, developing your social and political network. And by just practicing reading, writing, and speaking as much as possible about this to develop your expertise and become that subject matter expert. Then you can take a deep dive into our skill sets. We've organized a living and evolving list of essential skill sets that one might need to develop all or part of their professional expertise and their identity as an NPE across the career continuum, which can change. Your needs can change as you grow. And you might organize these a little bit differently, or you might share something that you think we're missing in them. And now we do have some netiquette that we follow. It's very simple because we believe in open access to these resources. We do record these sessions so that our community members across the globe who cannot always join synchronously each month can access this information. When we have a speaker, we get their consent to share this and have first rights to edits before we have our Zoom session. To maintain our psychologically safe space, we do not share the discussion that follows. There might be occasionally really robust Q&A afterwards that really adds to the month session and the discussion and conversation, but we carefully either edit this and include it without sharing the community member's name or face or voice, or if that's not possible, we ask for consent to do so before posting it on our website or YouTube. If you want to completely make sure that you avoid any type of this inclusion, feel free. Leave your camera off, stay on mute, and you can engage with us in the chat, which we never share. So here's some of the resources that we regularly share our material on. The online process includes a one-on-one navigation guidance for newcomers to our cafe and community. We onboard them to theoretical foundations, as well as the resources that we've developed so far, and the process for our monthly cafes. We have resources that are collectively aggregated in a multimodal repository for adult learning and various styles of learning. We have a modest website. It does serve as our centralized source for these efforts. These resources are infographics, we have roadmaps, educational content, links to springboard you to other resources that already exist out there that we don't need to recreate. We just kind of curate them for you. And our monthly Zoom Cafe sessions have evolved to highlight a speaker organized with this skill set so that we focus on every component of them as much as possible in a know one, see one, do one modeling. And we share this experience from nurses to nurses, and we share our dialogue about it. The implications are just that, at the very least, you as a nurse policy entrepreneur walk away from each cafe with a little bit more understanding about steps you can take to make an impact. We seek to empower nurses as influential advocates and full partners in healthcare reform, translating advocacy to policy. After dialoguing in our open door, judgment-free space, using our resources, and diving deeper into your why, we as nurses can build upon our practice of advocacy out in the world and in broader engagement. So let's get started.
I'm so excited that today we have a wonderful speaker from California, and this is Kenna Lee. I'm going to make sure I get your exact title right. It is very long, Climate Change Program and Policy Specialist for the California Department of Public Health, Office of Health Equity, which addresses cross-cutting issues related to climate change and health and provides a forum for communication, coordination, and education across agencies and with stakeholders, particularly local health departments. And what I love so much, Kenna, about you is that you have this beautiful breadth of nursing expertise from different realms and different fields before entering into this space, which became policy, but then turned back into community and now kind of mixes and mingles all of it, all the while going through some quite turbulent times here in the US. So really, really looking forward to the perspective that you brought into this space, the perspective you have now, and sharing your lessons learned with us along the way. Thank you. Welcome.
Thank you, Grace. That was impressive. It took me like a year to be able to say my job title without stumbling. Hi, I am Kenna Lee. I'm going to share some slides, and so there'll be a little bit more of a formal. Um, Let me make sure this happens correctly. Are you seeing my slides now?
Yes, we are.
Okay. Um, Yeah, there'd be a little bit more formal part of the presentation because I am a state government employee, and so everything goes through multiple levels of approval. Um, so there'll be a formal part, and then there'll be an informal part where I'm just happy to answer your real questions. Um, so, um, as Grace said, I am our local health jurisdiction climate change policy and program specialist in the local assistance unit of the Climate Change and Health Equity branch in the Office of Health Equity at CDPH, which is California Department of Public Health, where I work at the nexus of climate change, health equity, and public health. So I came into this role in a really roundabout way. I spent 17 years as a hospice nurse, and before that, I was working as a licensed midwife. I decided to go back to public health school specifically to leverage my healthcare experience in dedicating myself to more upstream climate work. And what I thought that would look like and how it's turned out have been so different. I encourage you to feel free to ask about that part of my personal pathway during the Q&A. I am speaking to you today from Coast Miwok and Southern Pomo land. While my personal work focuses on local health jurisdictions, I'm really proud that the work of the local assistance unit that I'm part of equally prioritizes working with tribes. So there's a position that's a counterpart to me that's specifically dedicated to tribes. Our whole team is committed to working alongside Indigenous peoples and following their lead as they work to uphold their sovereignty, dignity, and land base. And in the climate change field, we know we have a lot to learn from Indigenous communities as we try to adapt to the changing climate and about traditions, but also about attitudes of stewardship. There we go. So I know you guys invited me here today to tell the story of moving from clinical care to more public health and policy focused work. In order to do that, I need to share a little bit of my why. So as mom, I'm just incredibly aware that the climate crisis touches all aspects of health and well-being, affecting access to basic needs of clean air, clean food, water, shelter, and safety. The health impacts related to climate change can include heat-related illness and death, wildfire smoke, and air pollution-related exacerbations of cardiovascular and respiratory diseases, adverse birth outcomes, injury, loss of life. It goes on and on. One of the most prevalent and long-lasting impacts of climate change is the mental health impacts, which are shown in the pink circle here. In the US, 78% of households experienced extreme weather events between 2017 and 2022. And of those, 24% faced serious health problems as a result. Somewhere between 20 and 65% of survivors of extreme weather events experience mental health impacts following the event. So working to prevent and ameliorate suffering is why most of us became nurses. Like, this is our work. Sometimes when I look at something like that wheel on the left side, which I sometimes call the beautiful slide of doom, the scale and the scope of the problem can be so overwhelming. It kind of makes me shut down, feeling like it's too late. Everything's, um, it makes me question, does our action really matter? But this slide is here to show you why what we do right now does matter. And it illustrates how much the actions we're taking right now amplify into the future. Like, every day we're choosing which pathway we're on. And the fact that we're still choosing does give me hope. Because there's a huge difference between the dark red line at the top and the light blue line at the bottom. And most of that difference rests in policy decisions. So what you're looking at here is the amount global temperatures will likely rise or not rise as much in different potential scenarios of greenhouse gas emissions, which come primarily from burning fossil fuels like coal, oil, and gas, but also from our conventional agriculture system, deforestation, and of course, our massive wildfires that we experience here in California and in many other places around the world. The red line shows how much the global temperature will likely rise if we do nothing to reduce how much greenhouse gas enters the atmosphere, and the light blue line represents a radical reduction in emissions. All the other lines approximate the results of different amounts. The different places the lines end up on the right side of the graph represent the opportunity for change based on our current policy actions and choices. So how do nurses impact this, right? Like, as nurses, our work is often down in the pink zone at the bottom of this slide, right? So like at the health outcomes level. But in order to address those health issues effectively, we have to look all the way up to the yellow causes at the top. And like, this is not a big overview of climate change. This is just a sample of climate impacts. But in public health work, we talk about the root causes of disparities. So climate change is now one of these root causes of negative health effects that exacerbate health inequities. Every effect climate change has on our planet will cause a ripple effect in the health of all of its inhabitants. So one example, droughts can lead to poor crop yields, which lead to higher food prices, which lead to decreased ability to afford healthy foods for low-income households. Higher intake of affordable junk food then leads to higher rates of metabolic syndrome and diabetes, which can in turn increase people's risk of heat-related illness. So you see how the cycle goes. So while we've seen that mitigation actions, which is like what we do to adapt, are essential. Mitigation actions are reducing the amount of emissions. We have to, in the health field, look at those policy decisions. We also have to be looking at adaptation and resilience actions because the disparities in health effects are happening now. So how we deal with this issue of like, stuff is happening now, stuff's going to happen worse in the future, and we need to do this prevention and this addressing response all at the same time. What we try to do is prioritize strategies that address all three of the needs, like mitigation, adaptation, and resilience. So, and in our work, we see climate resilience not as people like bouncing back after disasters and other climate-related events, because the underlying conditions of unequal political power, unequal participation in decision-making, and unequal access to opportunities and resources will need to be changed in order to improve quality of life, health, and safety. So what we're envisioning is communities bouncing forward after disasters to a more just society in a renewable, sustainable economy marked by inclusive participation in the policy decisions that affect daily life before, during, and despite climate-related events. This bounce forward concept helps us frame resilience planning and actions to address this basic fact that climate change affects all humans, but some communities and individuals experience worse health impacts from the crisis than others. People with existing health conditions, inadequately housed, outdoor workers, certain communities of color, immigrants, very young or old, pregnant people, people with disabilities, people with low incomes, and those who are socially isolated face disproportionate risk of harm from climate impacts. So just for one example, here in California, in Fresno County, African Americans were 8.6 times more likely, and Latinx people 4.5 times more likely than whites to reside in areas with more impervious surfaces and less tree canopy, which means those areas have greater heat island effect and greater risk of flooding. So how can we address a problem as big as climate change through public health? Well, public health is what we as a society do to assure the conditions in which people can be healthy. So this is part of our work. We hold true to our focus on prevention and use our understanding of the social determinants of health to move toward this vision of a low carbon, climate resilient community that is a healthy community. So despite the mounting inequitable health impacts of climate change, addressing it represents an opportunity to improve living conditions and public health outcomes through no regret climate measures that can reduce emissions, increase community health and resilience, and address inequities. So like, what are these actions that we're talking about that can create a more perfect world? Creating living wage, low carbon jobs, infill development that reduces car dependency, maintains affordability, and does not locate pollution sources near people. When we build safe, appealing facilities for walking, cycling, and transit, creating healthy local plant-based food systems, urban and community greening, and other nature-based solutions. And of course, reducing building energy use through energy efficiency, weatherization, cool roofs, and water conservation. So this community in the picture, this is a community where we all want to live and work. For nurses working inside what often feels like a crumbling healthcare system, this vision might seem impossible, but it may be more possible than we think. I'd like to give a sense of how we're tackling this challenge in the California Department of Public Health. Recognizing that climate change is the greatest threat to health of the 21st century, we maximize our reach by collaborating with other agencies to address social determinants of health, such as economics, housing, land use, transportation, and employment through climate policy, and to improve living conditions with and for people experiencing inequities, and thus reduce vulnerability to these health impacts of climate change while improving equitable health outcomes in other ways as well. We embed health equity into California climate change policy and planning, and we embed climate change into California health policy and planning. We help leverage the billions of dollars that California invests in addressing climate change by embedding health equity metrics, tools, and considerations so that climate programs addressing housing, land use, and transportation reduce underlying inequities in living conditions to reduce vulnerability to the harms of climate change, as well as improve health equity overall. And at the local level, our Climate Change Local Assistance Unit, or IWORK, offers technical assistance and tools to support local efforts and build local capacity to engage on climate change and health equity. We convene a community of practice and have regular data-focused office hours covering a wide range of climate-related topics. And we provide personalized assistance to individual jurisdictions as they navigate their way through this rapidly evolving field. So here are some ways that we encourage LHJs to advance climate and health work at the local level. They are already on the front lines preparing for and responding to these health impacts of climate change, and they've expressed the urgent need to address the climate health crisis. The good news is that there are many points of entry for local health representatives to engage in. Integrating climate change data and objectives into community health assessments and community health improvement plans. And we've actually just published guidance on how to do that. Protecting from extreme heat, providing health input to local planning efforts, such as climate action plans, general plans, and local hazard mitigation plans. Providing health equity input to urban and community greening strategies based on population vulnerability and exposure data, which helps counterbalance like which of the people are more likely to come to the city council or the board of supervisors and ask for more parks in their area are not always the ones that most need it. Weatherization and housing improvements that save energy and improve housing and health conditions, supporting opportunities to safely walk, cycle, and take transit, collaborating with existing community health workers to address the health impacts of climate change, such as extreme heat and wildfire smoke. And finally, working with physical activity and nutrition programs to promote healthy, low-carbon food systems and engaging with local tribes. These are all things that local health jurisdictions are already doing in our state. So that's what we're doing. And what does that mean for you guys? Many people want to do something and don't know what to do. And that's, I think, a lot of what this cafe is set up to help people move forward. So this brings us to one of my favorite things. This is something that really moves me forward. This is the Climate Action Venn diagram, which is the brainchild of Dr. Ayanna Elizabeth Johnson. So, I know I spent forever trying to figure out where my point of engagement was going to be. It was a clinical nurse who was very unsatisfied with the work that I could do on my green team. And this really helped me find my place. Without this framework, I would never have gone back to public health school, first to get a certificate in climate change and human health, and then to focus on family planning for displaced people. So I just really encourage all of us to take a minute to think about these things, where these things intersect for us personally. And you can, of course, use this idea for more than just climate. It can work for any field, but Dr. Johnson and I hope that you'll use it for climate. Anyway, one strange thing about moving into public health for me is that now I'm around people who think like me all the time. I was like, I found my people. But then after about a year, I was like, this is very pleasant, but it's a little bit dangerous. For those of you who are still working nurses, clinical nurses, you have this like 21st century superpower that I didn't appreciate enough when I had it. And that is like, you cannot stay in a silo when you're a clinical nurse. You serve whoever needs you, regardless of their political beliefs. And in my current public health role, I'm not usually talking to the people who think differently, who are watching different news than I am. Like, my Fox News intake has gone way down now that I'm not in other people's homes all the time. In the field, you get to be with people, often in a very intimate way, who may think and believe differently than you, and you get to understand that they're neither evil nor stupid. You get to love them, and that is an increasingly rare gift. So, knowing your superpowers, I want to talk about ways you can engage from clinical awareness to political participation. So, clinical awareness, a million different examples we can use, but if you think back to that wheel of health impacts, heat is a great entry point. It's deadly, it's uncomfortable, it makes people crabby, it exposes obvious inequities in who can access cool spaces and who can't. So for clinical awareness, medications may make people more vulnerable to heat, including antidepressants, antipsychotics, anticholinergics, and ACE inhibitors. That's a lot of people. There's a lot of research happening now about how to best manage these medications in the context of extreme heat, which raises the stakes of your medication reconciliation interactions. So you're getting the best info possible. When you're seeing a patient, asking questions about recent heat exposure may be critical to a good assessment. They may be in a cool building with you now, but did they just spend 3 days in a hot apartment? And of course, this carries over to patient education. We have to understand the context in which people will be trying to carry out whatever instructions we're giving them. So for someone newly diagnosed with diabetes, we need to understand that diabetes can increase the risk of heat-related illness, and they have to protect their meds and blood sugar testing equipment from the heat. So like in this picture, this woman is doing everything right. Like, she's got her fan on, she's hydrating, she's checking for heat alerts on her phone. But we have to start becoming aware and being able to communicate that fans can end up increasing heat stress when temperatures are sustained at high levels, because they can prevent people from realizing how bad they feel. So fans are great, and then they stop being great. This essential context of what hazards someone is exposed to and what vulnerabilities they have is key to high quality care planning. Okay, so care planning always makes me roll my eyes, but because they can be a giant pile of time consuming virtual paperwork, but we can sometimes effectively weaponize them to serve the patient's needs. So here's my experience with that in terms of climate change. After the 2017 fires hit Sonoma County, where I live and worked, the hospice where I worked was very aware we needed to up our game with assisting our patients with evacuation planning. So we used care plans to track those evacuation plans, which meant in the next fire, which came 2 years later, and then 2 years after, the next year after that, we could dial up those care plans and see where folks were going and how they would get there. Of course, the first iteration didn't take into account the fact that with the next fire, they would also have public safety power shutoff events. So a lot of the places people had planned to go were without power, but we got better and better at being prepared for so many parts of this climate change fueled new normal of yearly evacuations of really fragile dying people. And those care plans expanded now to have power shutoff preparedness, extreme heat plans, as very few homes in our area have AC. Another place where we can think upstream is our protocols, often defined by a procedure manual. Because I was hospice home care, an example here is the use of plastic lined barrier sheets for infection control in homes. Of course, infection control is very important. And at some point along the way, our updated procedure manual suddenly said that we needed plastic lined barriers, which were required to put anything down in a home, which makes sense, right? Like, there could be moisture, it doesn't get through the barrier, but it doesn't make sense if you care about how much plastic is getting thrown away every day. So no one saw a way around this, like, this thing's in the procedure manual, we all agree it's a bad idea, until someone started thinking more upstream. Why is it in the procedure manual? Is this recommendation actually based on data? If not, how do we make a local decision to change that practice? And basically, no one could find any evidence that using plastic barriers makes any difference in home care infection control. It was just added to the procedure manual as a common sense measure. So we decided that we trusted our nurses, who are highly trained, to be able to assess whether a surface in a home was dry enough to use plain recyclable paper barrier instead, and use their nursing judgment to decide which type of barrier was needed. So we wrote out a new local protocol. And you can just keep working your way up. Due to the experience I talked about with evacuations, and we'd had to kind of find a way to hack our EHR system to get it to include patients' county evacuation codes in a searchable way. When we were merging with a larger health system, we were told we had to transition to their EHR. We basically said, sure, yeah, fine. Once you can tell us how we're going to be able to pull up a list of all the patients in any given evacuation zone. So the larger system connected us with their Epic engineering team, and they designed a new software feature allowing evacuation zones to become part of home care and hospice patient records. It's like a tiny example, but it can make a huge difference both to the patients and to the team caring for them. There's a really big difference between looking at maps and comparing them to lists of addresses so you know who to call to alert them so to get that they need to get out, and pressing a button to pull out the right list. And all over healthcare, people are looking at these kind of adaptations and at unsustainable practices and changing policies about how we provide care, like which anesthesia agents are preferred at any given hospital. Oops, I don't know why this is happening. Sorry about that. Little technical glitch. I'll get back to the right slide. Here we go. This is the place where we were trying to get to all along, right? Of course, if you're really looking at systems change, you can start getting involved beyond your healthcare system in your local government or even beyond that. There are many groups that will teach you how to work with state and national policymakers. You guys are one of them. And you can find your local climate action plans or frameworks with a quick search of your county or city website. It's amazing what you can learn and how big of an effect you can have by showing up at meetings and providing public comments in your role as a nurse. Wear your scrubs, wear your identifiers, identify yourself as a nurse, and people listen to you in a different way. And if you want to have climate conversations or any conversations at a higher level, a good way to start getting involved in policy is to understand what is happening locally and to be able to tell the story effectively. So for climate, one kind of larger tool that's available in the US is this Climate Vulnerability Index. It came out of Texas A&M, Dark Horse Analytics, and the Environmental Defense Fund, and it gives an overall climate vulnerability score. You can combine environmental, social, economic, and infrastructure effects on your neighborhood level stability and lets you explore specific indicators. It pulls in 84 sets of data to rank more than 70,000 of our US Census tracts, and it helps you see which communities face the greatest challenges from the impacts of a changing climate. It also has a great tool to help you understand how to use it. And I'll throw these links in a little bit later. The CDC Agency for Toxic Substances and Disease Registry developed an environmental justice index. And some of our federal tools are less available than they used to be, but there are cached versions of many of these things. But there are ways to find out in your community where there are unequal indicators for health. And that is a great place for nurses to be able to talk about. And it's helpful to know where the public stands on your issue. So for climate change, we have these great maps that Yale's been doing for a long time. And it helps us show people that in their community, how many people are concerned. Because traps that we can fall into around policy is thinking that we're alone in our concern or not being able to find our people. But like just from this map of the US, you can see that in all but 3 states, over half the population is worried about climate change. In addition, 2024 climate metrics showed 78% of Americans believing that we had a moral responsibility to create a safe and healthy climate for ourselves and our children. And of course, nurses can provide health messaging to bolster state and local policies. Most Americans agree we want a safe and healthy climate. We have moral responsibility to create it, which is just such interesting framing, right? Protecting health is a top reason Americans select for supporting climate solutions. Messages about protecting health are 5 times more powerful than messages about job creation. The number one message motivating action on climate change is protecting the planet for future generations, which is something that people trust nurses to do. So we are those trusted messengers. You hear a lot about trusted messengers. Nurses are one of them. Using a trusted messenger is one of the central tenets of effective climate change communication. Climate change is often framed as an environmental, economic, or national security issue, but framing climate change as a health issue increases public engagement and provides people with a greater sense of hope. Another promising strategy is focusing on the direct health threats from air pollution caused by burning fossil fuels. You don't even have to refer to climate change. And importantly, the health frame is especially effective at engaging audiences who are dismissive of climate change and the actions needed to address it. So on the right, you can see a little pictorial history of how we talk about climate action. And so this has to do with thinking about what is effective messaging, and it's not always what we think it is. So I can't tell you how much time I wasted over the last 30 years thinking that if I just told people how bad the problem was, they would take action. So now I pay attention to which messages are tested and work. So it's not polar bears anymore. And it's not even job creation. It's this little baby in this woman's arms having a healthy future. To help you find a pathway, if you want to get involved with climate change, here's a few resources that you can connect with. And like, why am I calling out these specific ones? There's so many options out there. It doesn't matter. There's so many on-ramps. This is just a tiny sampling. You can learn more. You can take actions. These ones are some of my best guesses for ways people in this room might want to get involved. But there's a million other ways: joining local Sierra Club chapters, joining your citizens' climate lobby in the US, running for local office, joining your medical reserve corps to help in disasters, joining or leading a local community emergency response team, talking to your neighbor, joining or starting a green team at your workplace. The point being, there's no one right thing to do, that there's just what's right for you, your patients, and your community. And so thank you for listening. I look forward to having a more informal conversation with you now. And this is my contact information. And yeah, that's it for my official slideshow.
Thank you so much, Kenna. I know part of the official representation of being in your position and this being an official presentation from CDPH made it a little bit more educational about your hot button topic, but I absolutely love that because we have to make sure, and we haven't talked about this for a little bit in this space, but you have to start with your why. You have to hone in on your why, figure out really what is making you tick, what's making you want to have that broader impact. And you very so eloquently embed your why in everything that you do across all the roles that you've held up until this one, including this one. And not only that, but you've embedded your why. It seems like the department has embedded it, California being very progressive, into the policy decisions it makes, like you were stating in your presentation. And I also love how, you could have talked about the technical gaps and why, between different degrees Celsius for climate change specifically, here's all the reasons, the differences between this level and this level. But you said it's the policy gaps that are causing between this level and this level to happen. And I really appreciate how much you've overlapped your why and the educational component of this with different approachable, stepwise, solutions that nurses at all levels can take. And I think it was directly translatable to anything, not just climate change, but also the things that you brought up were global, even though it was politically the US context, it's a global issue. So thank you so much for that presentation. It was really well done.
I think I have a lot of questions about your job role and how you transitioned from your hospice home care to this position as well. and what kind of skills would prepare for someone like me to do this kind of job in the future? Because I think really the intersection of climate and policy is where I see myself going. But yeah, this is kind of a multifaceted question. So I'll tee you up and you answer however you would like. But I'm interested in, yeah, that transition from like your clinical work, your hospice, home care work to the position you're in now. And then also in general with your position now, with NPEC, we're very passionate about that multidisciplinary approach and intersectoral. So how in this position, you work with other departments, like you were saying, within Department of Public Health and other governmental agencies to do the work that you're doing on a regular day basis and how that all kind of translates into the community. Take that with what you will, but I'm interested to hear what you have to say.
Thank you. You may have to like pull me back to some other because that was a lot. And I should have taken notes and I didn't. But I'll start with a little bit of like the more like nuts and bolts of like how did this happen? Um, Oh, thank you. So good at summarizing. Yeah, so I was a hospice nurse, I was a nurse leader, and I was not that happy as a nurse leader within a Catholic healthcare organization. There's sometimes when you don't want to know how much the bishop, who's not in your org chart, is involved in your decision making. So I went back to being more of a clinical nurse, but that leadership experience being on my resume was, I think, important in teeing me up to move positions. But of course, once you're in leadership, you can never really get out. So they kept like pulling me back in. So I ended up mostly although my job titles were not leadership, I stayed mostly in leadership throughout the rest of my nursing career. Um, I also took part in um, a larger organizational like health equity advisory group. And that was another thing that I was just interested in, but that turned out to be a like, really smart career move. Was taking part in this larger health system advisory group because that being on my resume definitely, I think, made the difference. Like public health is not that excited about like bringing nurses into non-nursing roles. I just say that's my experience. Nurses, they want you to have a certain amount of leadership experience and they don't count any leadership during which you provided any clinical care. So all the leadership that I did during COVID, when I was certainly not going to send nurses out to do things that I was not doing myself, that was just not how the kind of leader that I was as a nursing clinical leader. Um, all those years of leadership are like struck from the record because I also saw patients. This is not true for how they bring doctors in. Ooh, I'm excited to read that. Yeah, so it's not that I'll just say the transition is not friendly. Like I took a huge, huge pay cut and I had to fight for the job. I had to send back my resume and experience narratives about it like 3 different times. I had to ask for escalation and fortunately, I was encouraged to do that. But had I not realized that there was someone behind the scenes rooting for me, I never would have known that would have to fight so hard to get a job that I felt like eminently qualified for, and that I was taking a giant pay cut to do. Right. So, it's not that easy, but fortunately, so I had the leadership and I had this participation in a kind of policy setting group. Those things were key in making the transition. And then some of it, as many things in life are, was also just fortuitous moments in time. So Roe v. Wade got overturned by the Supreme Court. I found it no longer worked for me to work for a Catholic healthcare system in a country where abortion rights were not protected. That was a personal choice for me. I needed to leave my job. And I left my job, but it was that COVID was still happening. And a neighbor of mine was working on a team, like for a consulting firm that had a contract with CDPH to help with communications. Do I have any communications on my resume? No, I do not. Am I a nurse? Yes, I am. And somehow through the private sector and through the fact that my neighbor was like, we just really need help and we need it right now and you're smart. I got a job but for a consulting firm doing communications work. Of course, when I got into that role as a communications specialist, contracted privately with the California Department of Public Health, the team there was like, oh my God, we needed a nurse and we didn't know it. So there was very specific knowledge that I had that like we were writing guidance for nursing facilities, skilled nursing facilities. Like no one knew anything about skilled nursing facilities, but I had spent 17 years going in and out of them. And so my ability to talk to the people and it just opened up this whole world. And really my nursing experience was so valued by this team, but were not asking for it and they were not looking for it. So that was an interesting experience. Through that experience of working at CDPH, I honestly did not know they had a climate change branch. I was at that point, going back to public health school in order to work upstream. But where I saw when I looked at that climate Venn diagram, I was like, well, I've always been really interested in refugee work. And I have all this women's health experience and I have all this climate knowledge. And that's going to come together on like family planning for displaced populations. Like that's my research area. And that's what I focused on in grad school. And that's where I thought I was going. And I graduated from grads, but in the meantime, I still needed to have a job. So I became a communication specialist and then I applied to this climate change branch because everyone's like, oh my God, they're the nicest people in the world, which they are. And fought for this job over here. And then I was in this job and I'm like, I love this job. I'm doing upstream work on climate, right? Like this other thing that I thought I was moving towards. And the fact that I was in a public health program was essential to me getting this job, right? Like all the pieces came together where I thought I was going to end up, which was like, I don't know, working in Bangladesh, right? With refugee women. I sit at a computer all day and make PowerPoints, right? And I talk to people all over California. It's a very different type of work. It uses my nursing experience in a very different way. It uses much less of my nursing experience. I'm always looking for ways to like slot that in or have these meaningful things. So we're able to expand the work that we're doing as a branch because we have a nurse in the branch. I don't know if this is answering your question at all, but I'm giving you just kind of the whole big picture. So here I am.
I'm interested in your whole journey. I mean, I could probably pick your brain for a whole, 2 hours after this, but yeah, I think
Yeah.
that overall, because I think that I have so many things I could pick up from what you just said, but I think what Grace is saying as far as like nurses and non-nursing jobs, they don't know they're looking for a nurse. They want all these
Yeah.
different qualities in a candidate, but they don't even consider someone that traditionally, we're seen very differently by society worldwide. I mean, and
Mhm.
yeah, just using all of these skills that you might not have realized were relevant to this kind of position, in different creative ways. But yeah, very
Yeah.
interesting.
Yeah. So I think I'm a good case study for like how this transition, like what's possible in terms of like discovering all these synergies, but also just like it hasn't been easy and I make a lot less money than I used to.
Hmm. And we're really like nurses are the pioneers in this space for I think people always ask me what's my dream job. It doesn't exist yet. I think that in the future, as we continue to become at more visualized advocates in this space, then we will drive forward that systematic change that needs to happen, that systemic change, and that these positions will be considered for non-nursing roles to bring that expertise to the fore, but then also it would create more positions within our nursing field and healthcare for nurses to expand as well.
I think this is so relatable. I'll speak personally, but I think it's something that a lot of nurses can relate to. You know, when we're in nursing roles, traditional nursing roles, we can do anything. There's so many different ways to be a traditional nurse that has like a nurse in the title. But what's different about that versus entering policy or other spaces where it's a non-traditional nursing job, meaning nursing is not in the title, is that we can label it as something. And we feel that that means that we know what we are and we can just say it in one sentence. This is what I do. I'm an oncology nurse. I'm an ICU nurse. I'm a whatever nurse. But even though we could flip between any of those roles at any time, if we choose to, we can also step into these policy or other spaces where a nurse is not in the title, but it's definitely all the skills packaged in one person that a nurse can bring to the table. Like you were talking about, I didn't have communications on my resume before. But the difficult part is that when you are interested in so many things and you can see how your nursing skills, once you flip on that switch and realize your nursing skills are translatable to other areas, you see yourself in so many different positions. You're like, a nurse needs to be there, a nurse needs to be there. I'm a nurse, I can speak to that. But we don't have a very cohesive single sentence title or job description that says, this is what I do. Because we can do all of the things once we realize that connection, and we can insert the health voice and the nursing perspective in all policy or in so many spaces. And that's something that can be really, for me sometimes, maybe every other week, an existential crisis, right? Like, what am I doing? I'm not on this linear trajectory where I'm climbing this clinical ladder in a hospital anymore. But now it's like I have a portfolio career and I'm doing all these different things and all these different levels, where I can see the theme and the thread line where you've so eloquently honed in on, this is the research that I'm going to do. I'm not in Bangladesh, but I'm working on the thing that I'm really interested in. And it's really just making sure that you're keeping that why centered and embedded in everything that you do. And as long as it's cohesive to you, you learn, hopefully with help through this NPE cafe and community, to speak to how all those dots are connected and to be able to present that for another role that you're trying to get a job for, or to other sectors when you're trying to discuss bilateral agreements or something at the UN, or to NGOs when they didn't have a job title for a nurse that a nurse really needs to be in, or anything else. And being prepared by understanding that it is messy, but there is method to the madness, being able to speak to that and be ready and prepared to seize opportunities when they arise is when you are able to make yourself ready to do the hard work. And all pieces of that work matter. Even if you're in your home, behind your computer screen, making slides, every step and every piece of that culminates to the broader social positive impact that we can have in all these roles.
I love that. Yeah, I think
Question.
it is always like trying to let doing what you can be enough.
I've always felt like there was one thing that was going to land in the middle of that Venn diagram that was going to be the answer for everything. And so when we say things like, well, I'm a pediatric CV ICU nurse, right? Like, Grace, to your point about statements and encapsulating like what we do in one sentence, sometimes I do like that because it's very clear. It gives me a very defined expectation of what families can get from me or expect from me. But it does kind of help me achieve a little bit of self like satisfaction knowing that I have a defined role. It's not all kind of gone with the wind and ebbs and flows. But in reality, like, I come back to it like I'm a nurse. Like, no matter what I do with that, like, the nurse for me is the umbrella term that I kind of travel with, because I still to this date have not found one thing that lands in the center of any good Venn diagram. I think some days I wake up and I feel like a politician and I want to go over here and do this, this, this. Some days I'm in my clinic, clinician job at the hospital being a very good caretaker, and there I feel drawn to do this, this, this. And that stress and that pull, it feels like it's pulling me apart in different areas. And just like this morning, your slide about what heat does to medications, I was literally taking notes like, we should be having a discussion with our transplant patients about what summertime means for you. Like, why are we not doing that? So I think, Angelique, to some of the points that you made, I just wanted to like put a bow around some of the fact that sometimes we want to do it all. Nobody pays us enough to do the work that really needs to be done. And we don't always have the luxury of finding that one true thing. Like, there's no one true love in life. And sometimes I feel like I have to do that with this like advocacy work. I have to find what makes sense to me, but then I have to build the position, or I have to create the audience, or I have to find the right message. Like, it isn't about just waiting for the lucky thing to fall into my lap or to find that one website that leads me to the right group. It's like finding these people like you guys to build it, because it probably doesn't exist. And if it does, it pays terribly.
My shtick is that local to global perspective, and I don't think I really understood what that truly meant until I started working really close with different CBOs and in this role in public health. Um, and I think it is so important that even if you are looking upstream, that you are bringing the voices and the people who are working on the ground with you, and bring and even that and that pertains to, not just climate action, but so many different, nursing workforce issues or global health issues or what have you. But and with, indigenous wisdom as well, like you were saying, those community voices that are the ones experiencing the issues most intimately on the ground and have that wisdom to bring to the conversation. I don't know. I just feel like that community piece can be applied to so many different hot button, issues or passions for nurses, yeah, locally and globally, and it will look different depending on where you are in the world. But I think it's a key aspect of any sort of um, nurse-driven change. Yeah, it's certainly teaching me a lot of different skills as far as communication, and leadership, and that multidisciplinary aspect is kind of what I was interested in as well, because like you were saying, it's I think with nursing, especially, when we do find that hot button issue, it's really easy to get caught up in a silo and an echo chamber of, we all believe this is the answer, to this issue, or the answer to all the issues is, the way we see it. But really, that's not how the real world works, and involving all these different perspectives and voices is absolutely key to actually having a sustainable solution to anything you want to get done. And that involves going outside of nursing, outside of healthcare, and working with people who have different skill sets and expertise. So,
I'm glad you mentioned that, because the whole time I was thinking like the word that keeps coming to my head is positioning. Kenna, you touched on it with your messaging, like the polar bear no longer works, the jobs, image doesn't work. Like, the positioning is about the messaging, but also like, who are we as change makers? Because sometimes it is an echo chamber, and when you become a nurse, you feel very drawn to, well, I should belong to my professional nurses organization. And of course, you should. But that isn't the only place that we can go. And I think a couple of us on this call have been involved in different ways with the United Nations. And there's like the civil society kind of river, right? Like, all the CSOs flow through it. There's a couple different avenues into participation, but where are we in these other non-nursing or non-civil society spaces? That's something that, we can do from inside of these non-nursing institutions, is to be the person that says, we really can't do that. So sometimes I do have to put the nurse a little bit behind what my job title is, even though I'm going to be talking to you from that title under the perspective and the learnings of a nurse, to explain it in a way that people can understand, and to be the person that pushes
I
back.
think that this, it reminds me, I'm not sure exactly everything you said, but there was one time that you were giving an intimate talk, about what it was like once you got into this specific role, about having to coordinate between all these different stakeholders, the things that you learned about the politics of your policy role. And I'm wondering if you have any thoughts like that kind of like surround this, and being able to be that intermediary.
So before I was a hospice nurse, I was a home birth midwife. I've just spent most of my healthcare career in people's houses, right? or where they live, which might be a nursing facility or assisted living, but like in the places where people live. And it's just given me such a breadth of experience with different segments of the population. And this is kind of what I was talking about, like your superpower as clinical nurses. And it's just not, I didn't realize how unique that was until I didn't have it anymore, or I'm around people who don't have it in a way that I didn't used to be. And bringing that understanding of the true breadth of human opinion, I guess, or like what ways people live and values that drive their lives and the ways that those intersect and overlap with underneath these things we put on top of them, like politics and these things, but these like underlying values. And I find that I end up speaking about that in a very different way than other people in my field and in my organization. I don't know if I'm touching on what you were hoping I would touch on, Grace.
That's exactly what it was.
Yeah.
I mean, I can't say word for word, but yeah, definitely. I think it goes back to the messaging, it goes back to the positioning that we've been talking about, and being able to, again, translate our skills through communication to other sectors, whether it's making sure that everyone can kind of get on the same page and have this consensus, which is diplomacy, or if if we just need to do something else to make other people see why it's important because they're focused on a word meaning something different to them, when it's really, I think this is what nurses are good at, getting down to the core of it and finding that shared value is really what you're talking about. I always knew that this is how nurses could talk to other people so well, other sectors, not like, any person, but other sectors, other professions, disciplines so well. But the way you said it was a different way for me to think about it than before. We get out of our silos. I always think about professional silos when I'm saying something like that. But you talked about being around patient environments and getting out of our silos. And that includes talking to patients that have different perspectives. And that really kind of is a full circle moment for me. And the reason as to why we can communicate so well with others and get out of our silos is because of that patient care. But just saying it that way really, really stuck with me. So thank you for that. I don't know if there's anything more you wanted to say about that, but I wanted to highlight that.
No, I just really do think it's the source of much of our superpowers as nurses. I think it's the source of maybe, I mean, there's many reasons that people value nurses, but I think that's part of the source of why someone would say to Connie, like, yeah, you had me at nurse.
And I think we like Grace, we can hear that, be like, oh, that makes sense with my experience. But when you think about why the general population respects nurses, they wouldn't think, oh, because they're great communicators and facilitators and and can make those connections between these different perspectives and stuff. But I think that that's something of like, that's why it's so important for the nursing profession to verbalize what people may think but not actively recognize, I don't know, about our profession. And I think it just plays into what we're saying as well of the nursing and nurses and non-nursing jobs and everything too. Because like we know we can do it. Everyone within nursing knows how, how many amazing nurses are doing all these incredible things in all these different ways and different spaces and everything. But half of the battle or challenge or whatever you want to call it is convincing the rest of the world that we can also do it. But
Or even
part of the
convincing
fun, I
ourselves.
guess.
I mean, I think
Yeah.
that's what I hope part of this community
Mhm.
does is, I don't know, you hear these stories about when a little girl, a little boy sees themselves in another person in whatever position it is, whether it's leadership, whether it's an astronaut, whether it's president. I mean, whatever it is, you can see yourself in that role by seeing yourself in the person who's in that role. And when you have a nurse in a position that you think is so important, Angelique, for you, it might be something with climate change. Like Kenna, you have a nurse who's leading climate change policy in their own way, then you can see yourself doing that. And that is that no one see one do one modeling that I believe is so wonderfully powerful about this community that we're building together, is being able to see ourselves in these different roles and to think differently about how we can translate what we do to those roles.
I think there's a piece missing from the conversation too around this essential like skill sets, etc., that is important. And maybe you guys will be like, nah, but I do live in Northern California. I am a hippie. But I do think there is this essential piece of caring. Like we're not just good at communicating. Like we're good at communicating through care. Like we care enough to communicate, right? Like our desire and our building our skills around communicating across audiences, across different belief systems is because of the underlying true caring that we bring. And so that piece of, when we are naming our skill sets, it maybe is not something you put on a resume. It's, it's female identified, it's like feminizing, all the things. It's, it doesn't go fit into what we think of professionalism, but I think it is core and it is an essential piece of why nurses are trusted because we care. And it's a huge piece of why I'm good at my current job is because I care. Like I literally care about each of the local health jurisdictions and the staff at those health jurisdictions and how they're feeling about their work, as well as what the, outcome metrics that they're getting, right? And it's that caring that makes me good at my job. It keeps people inspired, it keeps people engaged because I know someone cares what they're doing. So I just wanted to say it out loud that is a piece. When we say communication, there's another piece underneath that's driving it.
I really do feel like, especially as we take on these really heavy topics, that those moments of filling our cup are crucial. At least that's my experience. So, really appreciate all you guys and the conversation today.
No, thanks for having me. This was a great group of people to spend a Saturday morning with.